Everyone, welcome to another edition of Ask NP Deidre with nurse practitioner Deidre. She is with Aspire. Is it Aspire Wellness Integrative Health? I always am afraid I'm going to get it. It's Aspire, ASPIREWIH.com. If you want to learn more about her services in Ohio, she's also available via telemedicine in multiple states. But today, we're talking about a little known vascular issue. I didn't realize it might be considered a vascular issue. I thought it was just a female issue. It's known as fibroids. And I learned this because I had an ultrasound this week. And it turns out, going public with this, is I have a 9 centimeter fibroid on the right. And it's interesting. I've been to the primary care several times and I've expressed a few symptoms here or there. And not once did she put two and two together that it might be a fibroid causing it. And I don't have an OB/GYN right now because mine decided to retire. And it takes about 6 to 8 months to get into another one here in California. They're very backed up in our area. And so I don't have any answers. So, of course, I get on the phone, nurse practitioner Deidre, with my friend, Dr. Mary Constantino, who's an interventional radiologist up in Seattle. And she says, yeah, that's something that we might want to do something about. There are multiple treatments to start with, both natural and also you don't need a hysterectomy, which is great. There are minimally invasive options available. There's the artery embolization or fibroid embolization, I think they call it, that she may be joining us live. She's in the middle of cases up there in the Northwest in the Portland area. So she may be popping in. So just in case, to be prepared, because she does these minimally invasive methods. But I'd like to start with, I want to know about fibroids. I want to talk about what exactly are they? What causes them? And I hear that there are even teas that you can drink, special formulated teas that can help with fibroids.
Okay, so let's put it into perspective, though, the size of your fibroid, 9 centimeters. That's the entire size of a uterus. So if you think of what the uterus size is, it's like the size of a pear, which is about 9 to 11 centimeters. And so this is a large fibroid. And so what are they? They're basically benign masses. They are not cancerous, but they're actually driven by estrogen when there's an imbalance of estrogen versus progesterone. And it can be that you can be estrogen dominant, or it could be you're in a life cycle where progesterone starts to drop also. And that, even if with a normal estrogen, would make you estrogen dominant because the progesterone isn't on board like it's supposed to be. And so many women experience this in their lifetime. They have fibroids, but some of the symptoms will be like heavy bleeding, what we call menorrhagia, or having like this bulk feeling, like they feel heaviness in the uterus, or they may have cramping because the body is like, what is this? Let's get it out of here. And so the body wants to cramp more. So to try to expel it, but it doesn't happen that way. And there's multiple different types of fibroids that can be an issue depending on where it's lying in the uterus. But in general, we see fibroids in the perimenopausal state when progesterone starts to drop first, because that makes women estrogen dominant. So any type of estrogen dominant state can cause a fibroid for sure. And then I think about like, who's more at risk, or who do we see have fibroids more? In African American population, those women tend to have more fibroids. And we actually don't know why. We just know that is the truth, that they have more uterine fibroids.
It's interesting. You had suggested the Vitanica dietary supplement for kind of a reproductive system support. It's advertised as pregnancy preparation. And I had started taking these in April. Probably wouldn't work that fast if it does work, but is that something, a supplement like that, that might help get our system back in check? Is it even possible?
So actually, it is when we balance out the hormones, and a supplement like that. You're looking for chaste tree berry because chaste tree berry or Vitex is something that's been studied for thousands of years to help balance women's hormones. And so when we're thinking about balancing women's hormones, that helps improve progesterone level. Now, knowing the size of the fibroid that you just described, I would say you need to be detoxing a little bit of estrogen too. So products like cruciferous vegetables, DIM is a supplement that we use, or calcium D-glucarate to help detox that estrogen. But what we want to do is help balance out the estrogen piece of this as well. And we can get what we call sulfation, where it helps us to detox estrogen through foods like broccoli, cauliflower, Brussels sprouts, broccoli sprout, which is the little sprouts. They're 100 times more potent than broccoli alone, so like a tablespoon of that every day. The flaxseed, which I already know you're doing, so 10 grams of that. These are
Except
all
I'm allergic
hormones.
to flaxseed.
Oh, that's right. That's right.
I know. I have the little spice grinder and I was just putting flax in everything. And although I don't have any sort of outward allergy that I could see, when I did the allergy testing, that was one of my top allergies, which I didn't realize. And just because you don't feel it on the outside or see the effects on the outside doesn't mean your arteries aren't reacting on the inside. So that was one of the things I had to stop taking, unfortunately.
Yeah. So,
Kind of annoying. Look who just joined us, Dr. Mary Constantino. So she'll be actually joining us in just a second. I think she's on the phone for a moment. So I'm excited that she's going to be joining us and we can both ask her some questions about this minimally invasive procedure for fibroids. But I want to get back to, you were talking about all those cruciferous vegetables and doing a detox. Is there a special supplement that can help, just amplify those efforts? I already try to eat healthy. I already try to eat a lot of vegetables such as that. And you said the broccoli sprouts, right?
mhm.
Um, that are really good for it. Any other, supplements that might help to amplify those efforts as well to join the, what did you call it? The
Chase tree.
chase tree berry.
Yeah, so definitely something like calcium D-glucarate can detox estrogen and help with the balancing of that. But with the larger fibroid, with that, definitely taking some work. As we go through menopause, though, as women go through menopause and lose estrogen, fibroids can shrink, but I'm super excited that we have Dr. Mary here to talk about like procedures and things. So used to be all women, like if you had the heavy bleeding and fibroids, you were offered a hysterectomy. Like you can almost look through a woman's family and know who had issues at that time because like I don't have a woman that ever made it to menopause without a hysterectomy in my family. So that just let me. So when would say, well, when did your mom go through menopause or what about your grandma? Not one of them. They surgical menopause very young. So
Yeah, Dr. Constantino, though, it's still happening. Women are still getting hysterectomies as frontline treatment by those who don't know that there's a minimally invasive option available, or simply that they don't offer it, so they don't tell people to go explore that as an option elsewhere.
Yeah. Can you guys hear me okay? Do I have a good
We can hear you
technical?
perfectly.
Yeah, I mean,
Meet
this is,
nurse practitioner Deidre as well,
yeah,
my co-host here.
yeah, nice to meet you. Yeah, she's exactly right. You can look at somebody's history, and a lot of times, I mean, there's so much about fibroids, like women don't know the history in their families because our grandmother's generation had hysterectomies at a young age without even knowing why they had hysterectomy. Our mother's age, those are women, usually 65 or above. Um, they may know they have had fibroids because it was entering into a little bit of a different era, or they may not. So she's exactly right, is that you ask your family's natural history, and a lot of them will go back and come back and be like, they just had hysterectomy. Did they? And then you ask them, did they have it because of fibroids? And most people don't even know why they had hysterectomies in the past, especially in the African American communities. And one of the biggest healthcare disparities on the planet, I think, is uterine fibroids because it affects 80% of African American women at the age of 40. And in particular, healthcare, I would say doctors. I can only speak to the MD world. I would say that we're known for being less communicative with minority populations or English as a second language, definitely African American women. So, what we need to do is stop doing that and really say, like, you need to go talk to your families and get these family histories. But we spend, in general, less time explaining things to women of color and people who are non-English speaking first. We're already doing enough of that to Caucasian women. So there is some racial disparity that drives me crazy, as well as the gender disparity part of it. I do not think it's enough to say you have fibroids and should have a hysterectomy. In the 20 plus years I've been doing this, I think that is reducing. Like, I see the positive push on this. I also am in the Pacific Northwest. So it's a little bit of a different culture than maybe the South or the East Coast, or, it's a little more uterine sparing, I would say. And women are like very empowered here to seek out lots of different methods of treatment. And we have a lot of naturopathic treatment and a lot of things in the Pacific Northwest that I don't think people have access to in other places quite as much. When it comes to consent, embolization was a level 1 treatment in 2009. And any conversation regarding fibroid treatment should include, I always include doing nothing, right? Always option to do nothing. And sometimes that is the best option. Sometimes it's not. Hormonal control, herbal, there's some herbs and supplements that work really well. And then once you get in definitive treatment, hysterectomy, myomectomy, UAE, and then there's RF with the SESA and MR guided HIFU. And all of those should be brought up with every female, in my opinion. So, and I think when it comes to hysterectomy, I mean, I'm not a gynecologist or a surgeon, but another thing we're seeing with hysterectomy, and this is stuff you see published, I mean, I didn't make this up, that the hysterectomy means a lot of different things. So open hysterectomy versus laparoscopic, transvaginal hysterectomy. So hysterectomies of a non-fibroid uterus is a relatively straightforward procedure these days. Hysterectomy of a fibroid uterus can mean a lot of different approaches. So I think that's important too when we're talking about fully informed patients, is what does that hysterectomy look like? So anyway, that was a rambling answer too. I don't even know if I answered the question, but I got a lot to say about fibroids.
So talk a little bit about the artery embolization, the uterine artery embolization that you can do.
Yeah, well,
and how do you know that it's the right time for it?
Well, great. Okay, so great question. So, the right time is when traditionally we say the right time for treatment is when the patient is symptomatic to warrant treatment. The problem with that is we've never established a cutoff at which by we say, okay, now you have a 5 centimeter fibroid, it's time to treat. Or now you have a 15 centimeter. So I've seen fibroids as big as 25 centimeters or, 10, 9, 2. I've seen 3 centimeter fibroids that are horribly symptomatic, and I've seen 25 centimeter fibroids, I'm not even lying, in 19-year-olds who are not really that symptomatic other than they feel like their belly pushes out a little bit. So fibroids, I always say they're like children. Like they all, to the outside world, you say children, they all kind of have the same. That's one word, but they are so different. Thank you. They are so different, child to child to child. Like when you know specific children, they're so different. Like our own kids are so different from each other, and where fibroids are. So if 2 people have fibroids, person 1's fibroids are going to be largely the same kind. Person 2's fibroids are going to be similar in person 2's body, but different than person 1. We know this because when we get an MRI measures the protein and water content of cells. And your MRI versus somebody else's MRI are going to look really different, which means the tumors are different. Their cellular behavior is different. We also know that there are women who grow 30 fibroids the size of little grapes. And then there's the patient that grows the one single watermelon fibroid. We know patients have fibroids at 19. We know they start growing them at 45. So what is that moment? And the reason I think a lot about this is because in my field, we do a lot of cancer work. these are things we think about in the tumor world, in the cancer world. Hormonally active tumors. We know that they grow in response to hormones, and I believe they also give off hormones. We know that the liver cancers that are hormonally active also release hormones. So this is where people like is it Deidre?
Yep.
Where Deidre, like all the medical management of this is nuanced. I think it can be really complicated. I love people who can really get into a lot of the advanced medical management because I think there's so many options. But my hope, and in terms of when they die off, the textbooks will say they die off after menopause. The problem with that is we don't really know that. So in order to really study that, you need contrast enhanced MRIs over the course of 10 years for like multiple different women to see what is the natural progressive death. What we know is I've never heard of a case of like an 80-year-old all of a sudden having a fibroid. Like that's a leiomyosarcoma until proven otherwise. So, but what about if you're 49? Can you develop a fibroid? Chances are low, but you probably can, right? Yeah. So what is that thing that sparks that? We don't know. We just say, oh, this is unusual. And somebody normally will tell you, oh, you're 49. This is, we want to make sure this isn't cancer. You should probably have a hysterectomy. When I get MRI, you can get these images called diffusion weighted images. Okay. So around where I work, I make sure the radiology people in my field, like who I send patients get MRIs, that they do these diffusion weighted images. The patient is not going to know whether these things are done or not. Most interventional radiologists don't even get these, and certainly most gynecologists wouldn't know to get this. What that does is it says if this is, by the way, the gynecology oncologist probably would know that these exist. And what that says is if this is if your fibroids are diffusion weighted imaging negative, they have in some studies up to 100%, although nothing's 100%, chance of not being a cancer. Okay? So if the DWI is negative, it's not a cancer. If the DWI is positive, it still is most likely not a cancer. So if I have somebody who says, I was 47 years old, I had a pelvic ultrasound, it was negative. I was 49-year-old, and now I have a 9-centimeter fibroid. I would say, that's a rapidly growing fibroid. Let's get an MRI, and let's look for those diffusion weighted images. Sarcomas are very irregular looking and very aggressive. So, I have seen them develop. Usually what the patient says is, I had nothing, 2 months ago, and now I have this big belly. So, and I'm kind of going down a pathway on this because you're talking about new masses over the age of like 45, our thought about sarcoma elevates, but we have ways to sort of filter people out to say you don't need to have a hysterectomy to figure this out. You can just get an MRI. So there's so much we don't understand about fibroids, and where I am now is thinking, why don't we have a cutoff that says, okay, your fibroid's 7 centimeters, you need treatment. When all we had was hysterectomy, you would say, if you can avoid a surgery, then it makes sense not to treat until things become symptomatic. As we are in the minimally invasive world with embolization, why aren't we treating every fibroid that's, once a person develops like a 5-6 centimeter fibroid, why are we letting them grow to 10, 15, 20 centimeters before we treat them? My job will be done when people present with small fibroids. Every single day, I see multiple people who present with fibroids that are, with uteri that are 16 centimeters, with fibroids that are 15, 8, 20 centimeters. So we're failing women in a way that we aren't ahead of these tumors. We're just chasing them. Embolization, I perform through the wrist. It takes me like 25 minutes. It takes me about 10 seconds to get down into the uterus. And I just inject these little pellets, and it cuts off the blood supply and kills the fibroid. It works beautifully with smaller fibroids. And by smaller, I mean, it can kill off any size. But once you have a 15 centimeter mass in there, then I question whether or not you want to keep a dead 15 centimeter mass in there, right? Because you can have bulk symptoms. And so at that point, and this is why I'm really like, hey, how can we have minimally invasive treatments that have been around since 1995? Uterine artery embolization has been around since it's published in 1995. Millions, probably at least 1 million cases have been done by now, but only about 5% of women actually even know it's an option. What has changed the landscape is things like this, and it's why I am such an advocate of things like this. It's women talking to other women. I tried to really, when I moved back to Pacific Northwest in like 2006, or I was here 2001. I went to fellowship and then at Georgetown and came back in 2008. I really tried to push education on fibroids, and I felt it very hard to get anywhere on it. And really, it's been women who are affected with fibroids talking to other women. That's been how we've made the most headway with having women hear about their options. Here's my final thing, where I think the future, what I want to see the future is, and now for about the past year, I've been talking to every single one of my patients who has fibroids and telling them, yes, we can handle you, but let's talk about your daughters, right? When your daughter is, why isn't it standard screening for every female at 25 to have a pelvic ultrasound who has a family history of fibroids? We know these things are genetic. We know 80% of women in the African American communities have it. How are we not doing ultrasounds? A minimally invasive, no radiation, inexpensive study to evaluate these uteri for fibroids. And here's how it changes people's lives. If you're 20 years old or 25 and your uterus has 4 2-centimeter fibroids in it, you know that this is going to affect fertility. So, I met the guy I procreated with when I was, I can't remember how, but we were like, let's wait 5 years. We have careers. When you know your uterus has a structural abnormality, it is fair to take that into consideration. And for us to be realistic and honest with people, like, you want to have babies, you need to get on this. You have tumors growing in your uterus that the best time for you to have these is now. They decide they don't want to have kids or don't want to do it now, fine. But why are we withholding this potential information from people? So that really irritates me. And it irritates me because I see those women when they're 38, 39, and they thought they could wait. And now they have a uterus fully structurally abnormal. And they weren't given the heads up. And that is very traumatizing to women, to be wanting children and being told you need to have a hysterectomy. It also is traumatizing for people who don't want to have children. Okay, so I'm not saying it's any more or less traumatizing. I'm just saying it's an added element of it. So I would like to see a position where all of the women who have a family history are getting an ultrasound at 25 and I'm making that number up at 25. Because I feel like you're probably not going to have big fibroids, or you're not going to have fibroids before that. I don't know, maybe you have one at 25 and 30. I don't know, Deidre, what do you think? I've done a lot of talking.
Well, I think that, we do have really young people with fibroids, and if their mother had a fibroid at a young age, I feel like it falls into that same way we would screen for cancer. We'd want to do it at least 5 years before we knew their mom had that, so that we can catch things early. I did want to ask about this imilization. So women can still get pregnant after they've had this with you. And so I want people to hear that so that they know that
thanks.
that's
It's
still
so
an option.
important. Yeah, I think what happened was, it's funny because the gyne literature for years I tried to go to the gynecology conferences, and there's a major one, the ACOG, American College of Gynecology, and speak. And before me, John Littman, who's in Atlanta, who's great at this too, he tried for years. My small, weird little minimally invasive field has tried to get on the stage at these places to talk about, as someone who does this procedure. We never can get out. We never are invited to speak there. So in the Green Journal, which is what the ACOG literature is, if you read that literature, it makes it seem like UAE is the worst procedure in the world. It never works. And, they'll say, oh, there's a 50% recurrence. And so the data that you're going to get, the data you're going to get quoted is very biased depending on who you're talking to. And I admit that I'm pro UAE. I'm biased pro UAE because I do a lot of it. And I'm like, I quote a 95% success rate with heavy bleeding and an 85 to 90% success rate with bulk symptoms. Those numbers are really high compared to what you'll see in the Green Journal. So what happens is, about every, I would say, 6 years, there's some massive influx of poor information that comes about UAE. At one point, it was nothing over 10 centimeters. The reason people said that was because way back when it was being studied in the early days, there was an arbitrary cutoff at 10 centimeters just so we can start to study it. But we certainly have embolized fibroids greater than 10 centimeters. Another one was pedunculated fibroids. Oh, you can't have UAE because you have a pedunculated fibroid. That's simply not true, number one. Number two, when you get your ultrasound report and something's read as pedunculated, what that means is it sticks off the uterus. It may really stick off the uterus, or it may just push out of the uterus. And so that word pedunculated should never say, oh, you're not a good candidate. So there was the 10 centimeter, then there was pedunculated. Then there was an era of if you have multiple fibroids, you are not a candidate for UAE. That's the most surprising one of them all, because UAE is great for multiple fibroids. Treats all the same, whether you have one or you have 30, it's the same procedure. Now, about 2 years ago, this like out of nowhere, it was you cannot get pregnant if you have a UAE. And I think this was largely driven by health insurance companies. United Healthcare has always had very funky rules about UAE, like that you have to have an endometrial biopsy. And I dictate on my clinic notes, an endometrial biopsy is not necessary and is like, it subjects the woman to unnecessary painful procedure without clear evidence of, I say something like that. I think the role for endometrial biopsy is actually, I'm not a gynecologist, but I think if you have obviously any spotting or any like kind of increased dysfunctional uterine bleeding that could be endometrial hyperplasia, that will need to be known. But usually you can differentiate those two. Anyway, it came out of nowhere, and it's totally not true. When it comes to fertility, they've looked at, what they did is they've tried to take all the studies with myomectomy and UAE. You can't, if it looks between hysterectomy and myomectomy, the answer is going to be have a myomectomy. Because if you have a hysterectomy, obviously you can't carry babies. So the only option was myomectomy. UAE comes along, and it's very hard to do those side-to-side studies because you're usually dealing with women who are older. Their fertility is less known. They have structural abnormalities already, so their fertility is dropped in multiple ways. And every study will be sort of like some favor myomectomy, some favor UAE, some favor myomectomy, some favor UAE. It's this kind of thing, back and forth. Personally, I think it really has to do with what that uterus looks like. If you've got a uterus with one fibroid hanging in the cavity, you gotta go get that cavity clean. That's a myomectomy. I just saw a patient who has 3 7-centimeter fibroids, and she doesn't have heavy bleeding. She has mostly bulk symptoms, and she wants to do IVF. And I said, nobody should touch this uterus because you may be able to do IVF without having any treatment of these fibroids. We don't know. I always tell people, try to get pregnant, we don't know that you're infertile, right? Like we don't know that these fibroids need to be treated. Try to get pregnant first. Anytime you have those fibroids, you are at risk for preterm labor. Anytime you've had a myomectomy or a UAE, these are the things that structurally damage the uterus. The downside of myomectomy with pregnancy is then you have damage to the uterine wall, and that puts you at risk for rupture. And that's like having a C-section scar. Yeah, so like if you have a 9-centimeter fibroid and this gets cut out of your myometrium, they're literally cutting, and that it disrupts the integrity of the uterine muscle. And that's what happens. So that's why, there was an era where we didn't allow women to have vaginal deliveries after C-section because the cutting through the uterus to deliver the first baby disrupt the muscle. UAE doesn't disrupt the muscle. However, it can potentially cause scarring and necrosis of the endometrium to a degree that we don't know. We don't know. We never go look with a camera. So it's anybody's guess at which is the best. So I try to be very, very careful and have really honest conversations with women about what's your number one thing you want here. If it's fertility, I'm working with reproductive endocrinology. I'm never doing a UAE until you've seen everybody. And we're talking about what happens if you can't get pregnant. And usually these are conversations that have to happen anyway because they're 38, 39, 40, 41, 42, all the way up to 47 and want to get pregnant. And they have not done a sperm analysis. They haven't done an HSG. Like there's all these other things. And then we somehow blame the fibroids when really it could be infertility for a lot of different other reasons.
But nurse practitioner Deidre. NP Deidre. Help. So obviously I am not a candidate for any sort of procedure at the moment. So still want to have kids. Have nothing right now in my future. Amazing boyfriend for a year, but we aren't close to getting married yet. But I still froze my eggs. I'm giving a lot of information publicly. Good for
Yeah.
learning, I think, for other people, but I think there are a lot of women that have, they have their careers as I have, and I'm passionate about what I do, saving life and limb, don't want to give that up. And maybe I should be focusing more on my dating life, my love life, with this revelation that we just uncovered. But I'm curious, even Dr. Costantino, you've mentioned that there are some natural means. You probably have seen things, fibroids shrink over time with the right balance, maybe detox as well, estrogen detox. So I'm thinking that might be a good option, as front line to try all of these different teas, the detox, everything else first, and then do that for how long to see if the symptoms alleviate, which would indicate the fibroid might be shrinking.
How old are you?
49, 50
Yeah,
in
you
two
should have
weeks.
you talk to Fertility about having babies while you drink your tea.
While I drink my tea.
Yes. Because you have a cavity right now that may be amenable to embryo implantation, but it may not be if this thing grows more. I mean, you don't know. You don't know. But yeah, I mean, I would say have babies with a guy or somebody.
Somebody.
Yeah, babies, stat.
Any
Yeah.
volunteers? No, I'm just
Yeah,
kidding.
who wants to have a
Um,
baby? Yeah, like I would say, like put conception high on that list. I would. I don't know. What would you say? Because I think that you're in a run against the time. You're in a race against this fibroid.
Yeah, and not only that is if we think about natural occurring menopause, average woman is 51, and so that's the cessation of stopping having our menstrual cycles, and so we know fibroids will decrease when we go through menopause for most women because estrogen feeds them as well. So yeah, you're on a time clock for both things that way, for sure. Like making sure that you make the decision. And yeah, even though there are women who have babies later, we know like when we look at all the data, the majority of women are through menopause by 51.
yeah, my mom was later, so I think I'm a little lucky there.
Yeah.
But in terms of have you actually, I mean, I think the key question is, I know that I did have fibroids a long time ago, and then I went on a few teas and supplements. I don't remember what I did. And I went back a year later and they said, oh, well, we don't see anything. There's nothing that's unremarkable. So I was thinking, well, maybe my body actually responds to these natural means. And maybe as nurse practitioner, you and I talked about back in April that there might be some hormonal things that are off, and I just need to get them regulated to stop.
Yeah.
Yeah. The progression, I don't know.
My threshold for things of when we try something and we say, is it going to improve hormones or balance hormones? So the life cycle of a follicle on the ovary is 100 days long. So we want to do something that 100 days and say, is it working? Is it not working? Like we should know something by then, by that 3-month cycle. And we see that across anything we do that manipulates hormones. So if it's not, then we need to get into something heavier and do something more.
So it'd be 3 months. We try something aggressive naturally. And this is good for everyone who's watching. Is this something because we always say that, we work a lot with people who have peripheral artery disease. Dr. Constantino does too, and so do you, nurse practitioner Deidre. And we always say frontline treatment is so anything you can do naturally, it's really worth doing for at least 90 days and seeing if it's effective, unless it's something that's acute. And if you are not in lifestyle limiting symptoms. I mean, how do you know when it comes to a fibroid if you're at a real threatening stage?
This is why we need a cutoff. This is
Mhm.
why we need to be able to say 9 centimeters. Okay. And monitoring. I mean, I would say monitoring symptoms, but once you're at 9, I mean, you could very well go to 15 and really not. I've seen renal obstruction. I mean, I had a patient who had so much acid reflux. She had ulcers in her esophagus because her fibroid was just growing and she just didn't really know. Her stomach just pushed out a little bit, but she was really, it was so big, it was taking up her whole abdomen. And when it was treated, her biggest comment was that she was like, oh, I developed breast again. And it's because she was actually eating. She was actually pretty emaciated because she had the feeling of fullness all the time. So there's all these kind of things. I'm like, how do you know? How would she ever know? She didn't know. She just knew that she wasn't hungry a lot. But she owned a business. She was fully functional, I mean, and so this is the problem, is that, yes, there's the like heavy bleeders, and a lot of women that I see, when they're changing a tampon like every hour, they're so depleted of iron and probably lots of other things, right? I mean, that's probably more your field than mine, but I'm like, I don't even think we fully understand what lack of iron does to people. So they're ultimately also like the biochemistry of this, you're growing tumors. So when older people have cancer, what do they feel? They feel tired or not themselves. Or, when you first get pregnant, the embryo is like this big, you feel tired and not yourself. So the process of growing things inside of us does impact our, I would say, biochemistry. And I say that like, I think that there are effects of growing tumors that we can't measure, we don't really talk about. So there's that. And then there's the effect of you are having heavy bleeding, and this looks like changing a tampon every hour, every 2 hours for like 3 days with clots. And I mean, the amount of blood loss that women have, then their period stops, and then they spend the next 3 weeks trying to amp that back up. And I'm always thinking about like, what's their bone marrow doing at this time? I mean, their whole body. This is a systemic
Thyroid and
thing.
yeah.
Yes, this is a systemic, and this is where Deidre is way better at this than I am. Like I just think about this stuff theoretically, and you actually treat it. But I think about the impact of this heavy bleeding. So it's not just the life disruption of bleeding through your clothes or bleeding on an airplane. I can guarantee everybody, when that little light goes off on the airplane and all the women hightail it to the back, those guys are all fibroid patients, about to bleed through their clothes. It's always boardrooms, plane flights. With COVID, women working from home, working closer to a bathroom, it was less disruptive to their professional lives. And so I've seen patients present. Now we're headed out of that now, but we were in lockdown for a couple of years here in Oregon. So, and people are now really just starting to get back to work here. But that ability to work is, it makes women incapacitated when they have these heavy periods. But if they're working from home, it's not as disruptive to their life. So their bleeding is heavier. So like a little unintended consequence of COVID. I love IV iron I always find it interesting to give people IV iron. It doesn't affect, because UAE is bloodless. So when you have the way UAE was discovered is patients were bleeding so heavily that they were not suitable candidates for surgery. They were too anemic. And I certainly have had patients have blood transfusions and, I mean, have such low levels of blood that they won't make it through surgery. So UAE was done, and it turned out it killed the fibroids and solved the problem. So one of the beauties of UAE is no matter what issue you have, you can still have UAE without an issue, without a problem, right? So you don't need blood transfusions for the procedure. You don't need iron transfusions. I end up with a lot of patients who are just not good surgical candidates. I mean, maybe they have autoimmune diseases or, MS, or the general anesthesia creates a problem for whatever reason, either for them mentally or emotionally, or truly like for some medical reason that they have. Patients who have had things like ruptured appendectomies or complex C-sections where they've had scarring or something in their abdomen that says this is not an abdomen we want to go operate in again. All of these patients are great candidates for UAE. So in my mind, there should not be a complex hysterectomy really done without a consideration for UAE. I work with a gyne-oncologist in town here because the complicated fibroid patients will be sent from gynecology to gyne-oncology for the surgery. If they're big and bloody, these are big bloody tumors, they can be embolized prior to hysterectomy, prior to removal. That's we do that all the time for like renal cell cancers. but why is this not a very common thing for fibroids? I don't know. And what that would look like I just had a patient who had her uterus about 17 centimeters, and coming off the back of her uterus was another about 10-centimeter fibroid. So she had maybe 9 fibroids, but had this big bulbous one taking out her whole posterior pelvis. That's a very challenging location for surgeons to operate in, the large posterior fibroid. So embolizing all of it, getting everything to shrink, devascularizing, taking these huge chunky arteries and taking them down to a devascularized fibroid, and then having your hysterectomy 3-6 months down the road is a much, I'd say, straightforward, easier procedure. I don't do that operations, but this is the feedback from the gynecologist. So there's a lot of creative things we can do like this that keep women, even women who are open to hysterectomy, out of that risk. But by and large, hysterectomy is the #1 procedure in women in the country, and fibroids are the #1 indication. About 700,000 hysterectomies. So we have a lot of work to do. The ACOG has sort of said we're doing far too many hysterectomies on women, and we need to consider other options. Interestingly, in most of their educational or their consensus documents, they don't have UAE as an option. So they'll talk about hormones or myomectomy, but they seemingly do not mention uterine artery embolization because they don't do it. We do it. So.
And what about downtime? So I think that is important, because when somebody gets a hysterectomy, you're looking at 6 to 8 weeks off work. Women aren't able to go back to work. And so what does that look like for somebody who's this career mom who, juggling all these things in life? What's the difference with the UAE?
Yeah, I love you for asking this question, because these are all the ways that motivate me in terms of, I'm a working woman, a mom of 2 children, and if someone told me I have to take 6 weeks off of work, I didn't even take that. I've never taken a sick day, and I'm 52. So this is just not in my language. This is a 1-week recovery time. And so for sure, I got this procedure covered by Oregon Health Plan. When I came back to town, it wasn't covered. And these things have, women, everything I do is motivated by patients, to be honest. And this gal this is the typical story. She was a child caregiver for the state. So she made, not very much money. She bled horribly. OHP did not cover UAE. They covered hysterectomy, but that was a 6-week recovery time. But if she didn't do her caregiving job, if there was a gap any more than 2 weeks, she would lose her state caregiving license. And so for years, 4 or 5 years, she couldn't get treated. So we just allowed her to bleed and bleed. So, but with the help of SIR, I use, this was when I was right out of fellowship. I turned towards our society and I was like, we got to change this. And I'll say that OHP was a very understanding, I presented all the data and they were like, yeah, we should be covering this. They just hadn't heard about it. Nobody had brought it to them. So she got her UAE and she did great. It took us overall about 3 years to get that done. But this is the problem. 6 weeks off of work, single moms, single women, working women, these are real consequences now. This is mortgages not being paid, bills not being paid. And there are women who just can't do it. And, I have treated doctors who are like, I'll have a hysterectomy. I don't care, but I'm not taking 6 weeks off of work. This is a 1-week recovery time. The reality is I've had people get on airplanes the next day because it's minimally invasive. There are no complications that can happen kind of once you leave in terms of the infection. There's no incisions. So from the wrist, we don't even use a scalpel. So once the catheter comes out, you just hold pressure for an hour and then you're done. You can walk out of here and go do whatever you want to do. You can't cause a complication. So I advise people to take a week off. I love signing women off 2 weeks from work. My general philosophy is their bodies are so challenged. And I always say Americans recover terribly. And a lot of this is about the mind body, your bodies are in stress. They're in stress condition. Not only are you bleeding, you're managing. And these are years of dealing with this and waking up at night to pee every 3 to 4 hours. We don't give that enough credibility for women whose primary issue is bulk symptoms. We're like, oh, you have to pee. Okay. But when you literally have to get up in the middle of the night to pee 2 times a night, every night for your whole life, or not your whole life, but, over one night, it's very disruptive. And so why do we minimize that? I mean, that's a real, I'll have lots of patients say, you know what, like the craziest, though, like you changed my life. The bleeding was one thing, but not having to have to go pee all the time is amazing.
Yeah, that's the one thing I know with me is that I kept wondering, and I've been just obsessive with my A1C, thinking, I mean, it has to, but
Yeah.
it's not. My blood sugar is so just normal. It's not that. And then I just discovered that it's likely this.
Yeah. We also like if you it drives me so crazy how much we minimize these things in women. So if you have to, so what this looks like is, and these are all stories from my patients. I'm driving my kid to school. I know where all the bathrooms are on the way. And that school is 15 minutes away, right? So I ask patients like, do you know where the bathrooms are? And you're driving your kids to school. If they say yes, we have a problem. Do you know where all your, do you, you know, you go, they're always like, I got to get up and go to the bathroom. Well, like I said, I got stuck on a plane, right? Like a plane should be able to be on a tarmac for 45 minutes and not have you in an utter panic about how you're going to have to, go pee. The waking up at night for sure. Exercise. So being able, and I learned this from a patient of mine, a very special patient of mine who actually used to work here too. But she was a runner, an Ironman, like a marathon runner, and did Ironmans, and would have to stop and pee like every mile and a half. And so we treated her fibroid, and she could now run like for however long she wanted to without pee, and which meant her running partners all now wanted to run with her. Like her sister was her running partner, was like, I'm so annoyed running with you because you always have to stop. And I mean, these are real, like and the thing
That's
is,
that quality of life that is
yeah.
so diminished by fibroids and what it does to women.
Yeah, and it doesn't go away. It's not like, oh, I just will handle it for 6 months and it will go away. This is
I'm hoping
years.
the team works.
I think you should get an MRI. I think I think that you got to hold off until you get pregnant. I mean, you should get pregnant triple stat is what I would say. Get pregnant really fast. Do all the non-invasive things. I bet you're going to end up needing some sort of treatment. Maybe. We'll see.
Yeah,
I would say
I'm
2 years. I would say 2 years from now.
2 years. Yeah.
Think. I bet.
But I'm coming to see you. So I got nurse
I'll do your
practitioner
UE.
Deidre now, and then I'm coming to see you.
Yeah, you'd be amazing. No, and you're so healthy. I mean, this is the thing, is that what would your fibroid look like in a non-healthy, like a less healthy person? And this is where that tumor growth is so variable. Like Deidre probably knows a lot about cancers and more holistic or naturopathic, or not, I don't call them alternative approaches to cancer, cellular, like around here we do a lot of vitamin C and other things. I don't pretend to be an expert on it, but the glucose control, right? There's all these other things that we do with cancers to control that cellular turnover. Why aren't we talking about, and you are talking about with fibroids, but yeah, this is what we should do. If you can hold off and avoid any treatment and never need a definitive treatment, that's the best thing ever. But we need to not let women get really too far down the road.
And I
Anyway.
think not dismissing symptoms and not just saying this is the way it is, you're a woman. I've had doctors tell my patients that, like, it's because you're a woman, and there's such gaslighting when it comes to women's health issues
It's so
anyways. So
it makes my job really easy because I know that we have won this with women when the majority of my patients don't need me. Right now, the majority, my consults are so easy because I'm like, oh my God, this is so clear. It's like, Kim, it's like if you came in with an ulcer and a CTO. Okay, well, you need an angio, right? Like it's so easy for me because my patients come so symptomatic. We also have traumatized a lot of women, and I am as Western as they come. I'm a surgical Western gal. Patient after patient has been so traumatized by things during childbirth or experiences like completely, you're right, gaslit. Or like I just had a patient today who I didn't see her today, but I dealt with this issue today. I mean, she had a real assault, and I say real, like brutal, and was in a court, everything. This was now many years ago, but cannot tolerate a exam. and her insurance doesn't want to cover the procedure until she has an exam. And I'm like, oh no, boxing gloves are going to come off with me and your insurance company because we are not violating a woman in that way to make you feel better. So this is a stuff that we will fight for. But I get checking boxes, but patients aren't boxes. Patients are individual people, and we have a lot of women who are traumatized by things that have happened, either being ignored during childbirth, almost dying during childbirth, being blown off, being told, "Oh, there's nothing wrong with you," and then they hemorrhage, right? That I am really try to personalize this, and sometimes my job is to get this fibroid under control, get the bleeding under control, get you into a network of gynecologists and practitioners and physicians where you're like, okay, I'm okay. And then we can slowly march towards, like, maybe you do need a hysterectomy, but let's do it in a way that is patient oriented. And I think that is a really important role for UAE. Surgery
That's
can be very traumatizing. Like, some people, I had a single mom whose husband died who was like petrified of anesthesia. She's like, I just have this, I can't go under it because if I go under anesthesia, I feel like I'm not going to come out, and then who will take care of my daughter? I had another gal, an Indian gal, who was the youngest daughter, and she was the only one that wasn't married. And she said, if I have a hysterectomy, my whole family will disown me. And she was in an arranged marriage, and she had a massive fibroid. And what happens, I immobilized her, and it was really big, and she ended up having an inflammatory reaction. She ended up with a hysterectomy, and in fact, her arranged marriage guy would not marry her. So these are real things that happen to real people, real patient stories. And anyway, sorry to rant over this, but I just appreciate the opportunity to talk about how real this is for so many women, and how individual people are, and how we need to stop like treating everybody the same and really get down to the dirty of why here's the other thing I wanted to say. Hormonal replacement therapy. Deidre probably knows more about this than I do, but again, being 52, from the age of, I don't know, whatever it is, 45 to 60 or whatever, that hormone replacement therapy is being advocated for. If you have a viable fibroid, that's going to grow the fibroid. So what I love about embolizing patients, especially as they hit that perimenopausal, is now you can be put in a category of, hey man, give them whatever kind of hormone replacement therapy they need without having to be in a war against the fibroid growth. So maybe, Deidre, if you want to talk to that. I mean,
Yeah, like with balancing hormones, like I said, progesterone we know isn't growing a fibroid, but estrogen is. And so when we're giving estrogen in that perimenopause, menopausal range, we do have to look for that. And so that assessment with people and understanding of what's going on is really important. Just there's so many options that are taken away when we just use a one size fits all, and that's not what we want here. And so like this is a really great option, I think, because I know even here, most of my physicians, if a fibroid gets to 5 centimeters, that they won't even talk hysterectomy because they're worried about the bleeding risk and everything. But then it's like, okay, well, you can't have hormones. We can't deal with menopause. You're having brain fog. You're not sleeping at night. Like quality of life is down. There's bulk symptoms, and they're not offered another. And so I think it's so important to get this information out there that there's other things that can be done, finding treatment and being able to utilize, because HRT is so beneficial for cardiovascular, bone health, everything. Like there's so many benefits, and taking that away from a woman just because of a fibroid, like, it's such a rough time going through
my
menopause.
dream would be, if we're in a situation, I mean, I got a lot of dreams around fibroids, obviously, but one of them would be, Deidre says this woman needs your quality of life. You would be better protected from all these things that happen. Plus, your quality of life would be great if you had hormone replacement therapy. I can embolize this patient in, I mean, literally, it is less than a 30-minute procedure, and there's no general anesthesia. It's 1 week. It's covered by insurance. Like, it's not a challenging procedure to do. There's no cutting. It works, and we just cut that question off. Like, take the fibroids out of it so that the next 5 years can look a lot better for you. Because it's not just 1 month, right? Like this hormone, I mean, like the hormone replacement, what do you do it up to 60 years?
It actually, you can do it longer. They say the timing of it, you should start within the first 10 years. But if somebody's on it, and like they're still going to get benefits further out, it's just managing it and it's
Mhm.
monitoring hormones. But most women will stay on it longer, 65-ish
Yeah.
or something.
Well, I learned this when I was in training. I finished med school in 2001. So somewhere in my training, I learned that any tumor postmenopausal is a cancer until proven otherwise. I think we talked about this. And this is a lot of still the same misconception. Again, everything I've learned from patients over the years. Early on, a long time ago, I had a patient who, she would fly down to LA for her hormonal health. And I just remember that because she lived on the coast. And I remember thinking she drove all the way to the airport, then flew all the way to LA. And she was like, and I'm never going off my estrogen. Now, as a 52-year-old female, I understand that. And she had bulk symptoms. And so the textbook would say that fibroid can't be alive. This bulk symptom, so the symptoms you're feeling can't be from your fibroid if you're postmenopausal. We did an MRI. Sure enough, it enhances.
Yeah.
I debated, should I be doing this? Should I not be doing this? The textbooks say we shouldn't do this, but I'm like, but here's a live fibroid in a patient. It's not a new fibroid. Why can't we do this? And so I did it, and her symptoms went away. This is how I've become to really appreciate those bulk symptoms. You talk to these patients afterwards and like, oh my God, this changed my life. And you think, really? Because I'm really used to patients being really, 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 really heavy bleeding and quote, all you have is bulk symptoms. And then, why we do that, I don't know, but we do, I mean, including me back in the day. And then you start to say like, okay, you have a fibroid and you have bulk symptoms. We're doing an MRI with contrast, and most of those fibroids will be viable. So it's the postmenopausal patients or perimenopausal who want to be on fibroids, want to be on hormones and need to be on hormones should just get immobilized. I don't think
Yeah.
I feel like that's like the complication rates are so low. So I don't know.
I just wish I was a candidate already.
You are a
That
candidate. You're a
just
candidate.
get it gone.
You're a candidate, but you need to have a baby. You need to have a
Yeah,
baby.
need to do that first. Might need to
Yeah.
have some
Yeah.
conversations.
Yes.
I don't
Yes.
like, it's one of those things that I remember when I was in my 30s and men would always say, well, your time clock is ticking. We can't date because you're probably in more of a rush. Here I am. And if I looked back right now, I'm 49 years old. I'm not married. And I'm thinking back, really, dude, back when I
Yep.
was 30, 31, my time clock was certainly not ticking at that point. I was
Yeah.
not ready. So wrong.
Yeah.
But now I am, just I'm trying to lean on my faith, a little bit, and also knowing you're there, which is amazing. If anyone can ever make it to the Northwest, I mean, I would travel from California up to the
Oh,
Northwest just to see you. And I have been
thank
doing some
you.
exploring since I think you and I had talked way back when I think I had a much smaller one. It was like 3 years ago, maybe.
Mm-hmm.
And so I wish I would have gotten guidance, as you said back then, versus, to say, hey, let's start balancing your hormones. Let's start having you drink these herbal teas back then. I wish I
Mm-hmm.
would have had a nurse practitioner, Deidre. This is why it's so
Mm-hmm.
important to me to be
Yep.
doing these types of interviews, because I don't think anyone's really doing this in the way that we are
Mm.
really trying to, as much as we can, get these conversations out there so that people don't end up, for example, where I am with 9 centimeters, where I should have started on these teas and the hormone balancing, 3 years ago, which might have helped prevent me from getting where I am today. We have Marcia who's with us, and she joins us in many of our conversations and knows that you can't find this type of content or opportunity anywhere else. She engages. We appreciate, Marcia, always that you have questions for us and you participate. So go ahead.
Okay, thank you, Kim. I'm in the pool, so excuse me.
I love that.
That's
I had to clean.
awesome.
We
She's
just
getting
had a
her
bad,
vitamin D.
yeah, we just had a bad storm. But I have an umbrella for sun protection. Um, my question is, and it's a little off subject, but not, you were just talking about like the importance of hormones. Well, I had a complete hysterectomy many years ago. I'm in my 60s now. But I've never taken a hormone. And why should I have, or why did you like indicate that women should take hormones?
So, hormone therapy, love this question. First of all, estrogen is protective of the heart. Like it has cardiovascular benefits, keeps the vascular walls more flexible. So there's a lot of, and bone health. And so I've been talking a lot about bone health because if a woman gets osteoporosis and has a hip fracture, we have a 30% chance of dying. So the only things for treatment of that is hormones, impact exercise. You know, I know people say optimize your vitamin D and calcium, but it's not going to do as much as hormones it's going to do for your bone and cardiovascular. So there's so many benefits. People look at it as a longevity med, meaning like longevity, not we're going to live to 150, but we want to spend less years with, you know, like most of us spend 20% of our life with a disease. We want to spend less of a percentage in disease, and hormone replacement can help with that. And we know that when women go through menopause, and after the loss of estrogen, that's when we start to see cardiovascular disease increase, cholesterol levels change, insulin resistance, diabetes, all of that. It's not typically prior to when we have estrogen on board. So there's this protectiveness of estrogen. So that's
Is it too late? Like I'm 66 now, and interestingly, I worried about osteoporosis and all that, but I just had a bone density test, and I forget now the number, but my doctor was like, "You are doing great." So that isn't an issue. So, but it's too late now in my 60s to start it.
So
I'm
actually,
66.
it's not too late. The timing, the hypothesis, meaning if you would have started earlier, you would have gotten more cardiovascular protection. Does not mean that you won't have benefits of HRT starting later. Also, when they did that WHI study and everything, it was in older women, but we do know that a topical estrogen would be better because less likely to have any issues with clotting or stuff that people worry about, although very minimal issues with having a blood clot or anything on hormones, even less with topical. So there's still treatments available for women who are 10 years out.
And you think like into your 70s even?
I do have patients
Yeah.
76 and older that, yeah, are on
Oh, that's
HRT.
good. Okay.
I'm a firm believer in what HRT can do. Like I've seen it. I see these women out, you know, still gardening, still walking, still doing all the things because, you know, they're on HRT.
Interesting.
I would,
All right,
this is more her field, but I would, as a very Western person, also say this is what we're all hearing too and understanding. And
Okay.
the vaginal estrogen, because the worry is that estrogen is going to cause DVT, and the vaginal estrogen doesn't even get absorbed in that way. And so when they look at urinary tract infections, which in my field where people get septic and when you get older, you get all these recurrent UTIs. And I think this has been studied to some degree, although Deidre, you probably know better than I do what these studies say, but this is what I'm hearing, that the vaginal estrogen affects the mucosa, which decreases the UTIs. So really, if you're somebody who has recurrent UTIs, or even if you don't, the vaginal estrogen is protective from these things. So maybe
do you
you're
imply that? Is that put in like a tampon or something? Like you put something in a tube and kind of shoot it up?
Deidre?
Yeah,
I've
it's
never
an
prescribed it.
applicator. Yeah,
Yeah.
they have an
Like a
applicator
tampon.
for it.
Kind of.
Yeah, yeah. Or some women, they make even vaginal estrogen in these little gel caps. They make it in a little pill form. Like there's several treatments to vaginal estrogen. So they have listened to women and know that not everybody wants the cream.
So there's a podcast. I don't know if I'm allowed to say this on but
Yeah.
Peter Attia some people love him, some people hate him. But Rachel Rubin, do you know her, Deidre? Rachel Rubin did this podcast on Peter Attia that was really, really good. And it's a lot about, they talk about how much hormone treatment and menopausal treatment doctors get in gynecologic residencies, and it's like nothing, like less than an hour, for all of residency. So I think we have a lot to learn from Deidre and the other people who are in the menopausal. But this Rachel Rubin does this podcast and is really, really good. So I'd encourage you to listen to it if you've got time in your pool. Thank you.
Awesome.
What fun.
Well, thank you so much, everyone, for being on. Any final thoughts, Nurse Practitioner Deidre and Dr. Costatino, just the takeaways that each of you might have for those that are struggling? Again, we deal with vascular and cardiovascular diseases, and fibroids are a little known vascular issue that is incredibly important. And I think it's evident by the fact that it's, the UAE you can go in, you can embolize those vessels, the collateral vessels that are attaching and helping to feed these fibroids. You go ahead and you cut off the blood supply to those things and the fibroid dies. So that's a really great indication that it is a vascular issue and it can be solved with vascular methods.
Yeah, I'm so thankful for this episode and for you sharing this option, because it is going to help so many people to have that conversation with their providers if they've been offered only hysterectomy.
Yeah, it should never happen in this day and age. And I was pretty gentle about saying things like that at one point, but now, since 2009, it's been a level 1 treatment. And so we do have informed consent. And I do think all of these options have to be discussed, or you haven't had informed consent. And I'm always happy to see anybody. We do have people fly in for treatment. We try to make it all easy for people, but this comes out of some very deep, strange passion I developed for fibroids in 1999. I don't know why. I don't have fibroids, for the record. I think a lot of people probably think I do, but I am obsessed with them. And I think it's because I've just treated so many women, and I just feel so many of disparities, and I have a lot of job satisfaction with the ability to individually help women where I can. So thanks for doing this. It's such an important way to get the word out. So you're so awesome, Kim. The fact that you put your personal story out here is applaud you so much. Thank you.
Thank you. I'm always about using, my experiences to help, other people, even if it is a little embarrassing to put that kind of thing out there, and especially put it out there. The fact that, I am scared. I don't know that I have an opportunity to have kids anytime soon. I would like that, even if I wasn't in my situation I am now, that I'm very happy in. You get into another situation and you still have to wait, right? You still have to then go through. So, it's crazy. So anyway, I appreciate you both being here. Thank you for your support. I hope this helps other people that are tuning into this. I think it's very important information. I think it's also important for patients who have, who are not surgical candidates, to know that they do have other options such as this that are available, whether it's natural through what Nurse Practitioner Deidre was talking about, or through UAE. And if people want to contact you, Dr. Costatino, if they can get to you, what is your website?
It's advancedvascularcenters.com. So advanced vascular centers. That's a long word. I was going to say, so you could just usually Google search fibroids Portland and I come up. But anyway, Advanced Vascular Centers or my name. I don't know. There's not very women in my field, so.
I love it. And Nurse Practitioner Deidre's is it's Aspire, ASPIRE, WIH.com. And make sure you do